Welcome everybody here in Fitkin and online as well to the 11th annual Sreedhar Nair Endowed lecture. It's my great pleasure to introduce the lecture today, and I thought it would be nice to have a slide and just honor Dr. Nair properly before we start. So I'm just going to read through this dedication that Dr. Mathey put together. So Dr. Nair was a major national and international leader in pulmonary medicine. He came to the United States from India and trained in pulmonary medicine in New York City. He was one of the first physicians to take and pass the ABM examination in pulmonary medicine. Sri, as he was affectionately known by his many friends and colleagues, practiced in Norwalk Hospital in Connecticut, where he was chief of pulmonary and critical care medicine for 24 years. In the mid-1970s, Dr. Nair founded the National Emphysema Foundation, supported largely by his many grateful patients. For more than 5 decades, his foundation has funded research projects in Connecticut and throughout the United States, and has been a major source for lecture support at academic medical centers, including here. Dr. Nair was also a founding member and past chairman of the International Society for Computers in Critical Care and Pulmonary Medicine, and a consultant to the World Health Organization. The American Thoracic Society awarded Dr. Nair the International Health Award for his contributions to pulmonary medicine in India and other countries. With his wide vision and wisdom, Sri was a supporter of telemedicine years before it became important in the United States and throughout the world. After Sri's death in 2014, his family and the National Emphysema Foundation endowed an annual lecture in his honor at Yale. We are very pleased to welcome Dr. Taylor-Cousar as our 11th annual Sreedhar Nair visiting professor and PCCSM Grand Round speaker. So I put together a slide because I went through Dr. Taylor-Cousar's 94-page CD. That's just the abstract, and I have to summarize it a little bit. As you can see there, she is the acting chair of pulmonary medicine at National Jewish. She is also the co-director of the adult CF program, director of the CF Therapeutics Development Center, the president of the medical staff. She has professor appointments at the University of Colorado as well, and she has extensive appointments that are highly impactful and meaningful within the CF Foundation. These are just 4 out of a dozen or more than a dozen of them. Surprising nobody, she is also the top doctor in 5280 magazine at Castle Connolly, and she is also the chair of the ATS International Conference. So if you like the conference a couple of weeks ago, then you have Dr. Cousar to thank for that. So apart from her 8 New England Journal papers and her 8 Lancet Respiratory Medicine papers and countless grants, what I really admire the most about Dr. Taylor-Cousar is that she's an outstanding human being, and she is a dedicated mentor and teacher for many of us that have worked in this field. You might not get it from how humble she is, but Dr. Taylor-Cousar has been at the forefront of an enormous transformation in the field of cystic fibrosis. So when I was a fellow, maybe 10 years ago, when I was learning about cystic fibrosis, CF was still a disease of children. It was considered lethal in most cases, and our patients were very sick. Their life expectancy was in the 30s. People did very poorly with CF. And just in a course of 10 years, we underwent an enormous transformation where we almost doubled life expectancy. Our exacerbation frequency, our inpatient services were significantly less busy than before. And CF went from being a disease of only children, or predominantly children, to now a disease of adults that live longer and longer and in better health through their lives. Dr. Taylor-Cousar has been at the forefront of that. She has participated in, I would say, nearly every significant clinical trial for drug development in cystic fibrosis, in the discovery of unique clinical features that allow us to now understand CF in a more diverse, more reflective approach to how we treat and diagnose our patients. She has really led the field forward. And she has done this with grace and generosity, and truly as a role model for all of us. So it is my great pleasure to introduce my friend and collaborator, Dr. Taylor-Cousar.
So thank you for that really kind introduction, and thank you very much for the honor of being here, Dr. Mathey, Dr. Brito, for this lecture, this name lecture series. And I also appreciate the hour of your time. I know how busy things are right now. So it's really, honestly, my great privilege to talk to you today about one of the greatest success stories in medicine. So these are my disclosures, most of which are related to the fact that I run a lot of clinical trials and I'm frequently consulted on their design. So our learning objectives today are to describe the history, basic pathophysiology, and treatment of CF, identify the importance of the cystic fibrosis transmembrane conductance regulator, or CFTR genetics, in our current therapies, recognize the existence of inequities in the diagnosis and treatment of people with CF, who identifies individuals from marginalized communities, and then describe the progress that's been made in future directions. So we will briefly run through pathophysiology and treatment to make sure that we're all on the same page. Like it's advancing. And then a case of an individual with CF, look at CFTR-directed therapies and the future of CF therapy. So back in the 16th century, there was European folklore that a child that tasted salty when kissed would soon die. And then there were these case reports of these kids with horrible malnourishment, steatorrhea, so loose, greasy stools, and meconium ileus that we also think were related to cystic fibrosis. But it wasn't until 1938 when Dr. Dorothy Anderson, who incidentally wanted to become a surgeon but was not allowed to do so back then and became a pathologist, and she described a disease she called cystic fibrosis of the pancreas. Unfortunately, she described this disease based on the autopsies she was doing of these very young children who were dying, who had mucus plugging of their glandular ducts and replacement of the pancreas by cysts and fibrosis. Then in 1943, Dr. Sidney Farmer coined the term mucoviscidosis. So he said CF was a multi-system disorder, the major manifestations of which were chronic bronchopulmonary infections, malabsorption and steatorrhea, and growth failure. Then Anderson and Hodges actually recognized, and for those of you who have to take your boards, that this is an autosomal recessive disorder. And so each pregnancy, there's a 25% chance when two carriers mate of that baby having cystic fibrosis. Then the story goes that there was a heat wave in New York, and Dr. Paul de St. Ignace, who was actually a mentee of Dr. Anderson's, thought that there was something going on because these kids with CF kept coming in with severe dehydration. So he hypothesized that there was something wrong with the sweat gland, and then went on to put kids, not their heads, but the rest of their body in plastic to measure their sweat, and indeed described the fact that there was a problem with the sweat gland. So people weren't reabsorbing chloride, so their chloride secretion was quite high and they couldn't reabsorb it. So in the sweat test, the sweat chloride what was diagnostic of CF. And today, even though we can do genetics, the still gold standard for diagnosing CF is the sweat chloride. Again, for those of you who have to take boards. So CF is unlikely if the sweat chloride is less than 29 millimoles per liter. 30 to 59 is considered the indeterminate range, and greater than 60 is diagnostic of cystic fibrosis. Again, the gold standard for diagnosing CFTR dysfunction is by using the sweat chloride test. Then people actually recognized that this was a multi-system disorder that required multidisciplinary care. So both at Harvard, in Boston, Harry Schwachman, and then Leroy Matthews in Cleveland developed these first CF care centers that were multidisciplinary in nature. And that started to improve the outcomes for these kids. But in 1955, the CF Foundation was actually formed by parents and physicians who really wanted to figure out how do you make these kids live longer and healthier lives. They also started to recognize that there were different practices between different centers, and to really figure out what was the best practice, they needed to combine data in a registry. So Dr. Warwick was actually commissioned to start following all of this data in a CF registry, and that registry is still used today. So every single encounter with a CF patient, their data is put into this registry, and that's how we've been able to describe the changing epidemiology over time. And people still are consented when they come to the CF clinic to have their data put into the registry, and I'll show you some of this data later. Now fast forward to 1989 when a collaboration between Lat-Chi Choi, Jack Riordan, Francis Collins, Batsheva Karem, and others discovered the CF gene. And of course we thought at that point that CF gene therapy would be around the corner, which we'll get into a little bit later. That obviously did not happen, but a lot was determined about the CFTR gene. So the gene encodes a protein of the same name. That protein sits at apical membranes in mucous membranes and is an anion channel, through mostly which we think about chloride, but it also has bicarbonate that goes through that channel, and there are effects of on other channels like the ENaC channel. One of the things I think is really hard in CF is trying to figure out how you go from this genetic defect to this protein defect to people dying of lung disease. And there's this video from the foundation that I think really helps a lot with that. So in this video, we're going to go down the airway, hopefully. Yeah. May not have I don't know is this from the link that I sent you? I downloaded the video. Well, essentially what happens is that we usually go down the airway in this video, and we all are sitting here right now with this very thin periciliary liquid layer and a very thin mucus layer that overlies that. And through that very thin liquid layer, your cilia can beat back and forth. So if you inhale something that you're not supposed to have in your airway, those cilia beat back and forth. You move it up the mucociliary ladder and you can cough it out. In the case of CF, you don't have the chloride channel function. So usually chloride flows through, water follows it, and you can regulate that periciliary liquid layer. In the absence of functioning CFTR, you cannot do that. So the mucus layer becomes very thick. You lose that periciliary liquid layer, and the cilia can no longer beat back and forth, and that acts as a nidus of infection. So infection sets in, your body's natural response to infection is to fight it off with inflammation, but unfortunately in CF, that inflammation does not kill all the bacteria, but ultimately starts to damage the airway. You get into this vicious cycle of infection and inflammation that ultimately leads to death from pulmonary disease. Now, at this point, we know that there are over 2,000 variants in the CFTR gene that can cause problems with your CF. About 1,000 or so have been fully characterized. And we've also realized that the protein dysfunction that is caused by these different variants really translates into the type of disease that you have. So, for example, under the normal situation, the gene is transcribed, translated, processed, moved up to the cell, and that's where it functions as chloride and bicarbonate channel. In Class 1 mutations, so those that end in X, so the nonsense mutation, most of that protein is actually discarded because it's not actually functional protein. And so you don't ever get it to the top of the cell to function as a chloride channel. In Class 2 variants or mutations like F508del, the protein is actually made, but it's misfolded. So again, the cell discards most of it, and most of it never makes it up to the top of the cell to function as a chloride channel. In Class 3 variants, such as G551D, you actually do get protein to the cell surface, but that chloride channel won't open. So you can imagine that you would have very severe disease if you have no function at all of your chloride channel. In Class 4 variants, like R117H, you actually do get protein to the cell surface, and the chloride channel opens some of the time, but it doesn't open enough. And there are some debate about Class 6 and Class 7, but you can also have variants where there's a lot of turnover because there's a slight variation in the splicing. But again, you might imagine that if you have no protein versus some protein, you're going to have a difference in your disease state, and that's actually what we see. So on the y-axis here is CFTR function, and on the x-axis is the clinical phenotype. So when people have two normal copies of the CF gene, they have 100% of their CFTR function, you wouldn't expect to see any symptoms. But as you have less and less CFTR function, depending on the CFTR variants that you have more and more manifestations of CF. So you can think sort of as two other buckets of those proteins that don't work at all and those proteins that have a little bit of residual function. And we'll get into the differences between those two buckets in a minute. But just to sum up the pathophysiology, you start with a CFTR gene defect, you move on to having an abnormal CFTR protein that leads to defective ion transport, particularly chloride and bicarbonate. You get a depleted airway surface liquid layer and abnormal mucus, and then you go on, you have defective mucociliary clearance and host defense, and that leads you into this vicious cycle leading to early death from lung disease. Now, with that stage set, I just want to put in this case that we'll get back into a little bit more later. So this man came to me at 35 years old. He was Southeast Asian in origin, and he'd had symptoms since early adolescence of coughing and sputum production and wheezing. So he also had a lot of nasal congestion. He had no history of steatorrhea, constipation, or difficulty maintaining his weight, and no joint pains or night sweats. He did have a history of horrible allergic bronchopulmonary aspergillosis, and he, in fact, as a child, had bronchial casts because his APA was so bad, and he'd been treated multiple times with steroids. He also, on CT, had bronchiectasis and pseudomonas. And at some point after he'd come to the States, people were like, oh, well, you have a lot of symptoms of CF, maybe we should test you with a 32 variant panel. So he was diagnosed as a CF carrier. He also had chronic sinusitis and nasal polyps, and he had MAC on cultures twice, as well as congenital bilateral absence of the vas deferens, or CBAVD. So with all of this, he was not diagnosed with CF, but he did get referred to me after he finally had his child through in vitro. He had no history in his family of chronic respiratory disease, and at that point he was working on a work visa as a full-time engineer and married with this infant who was born via ART. On exam, his stats were 94%, which even in Denver is a bit borderline. His BMI was normal. He did have really bad rhinitis and decreased air entry on exam, but didn't have any clubbing. Unfortunately, this 35-year-old had an FEV1 of 38% when I met him, and really severe bronchiectasis by CT. And so, of course, being a CF doctor, I went to the gold standard test, and he had a sweat test that was in the 70s. So we went on to do Ambry, and he had F508del and an ultra rare variant. So again, 35 years old, he just had his first child, and his lung function is in the transplant range, but he is on a work visa and about to get deported because he's going to lose his job because he's constantly on IV antibiotics from being so sick. So we'll come back to him later. So since people really understood the disease of CF as a clinical entity, there were 3 pillars of treatment that we really focused on. That was repleting and maintaining nutrition for those who are pancreatic sufficient, which is about insufficient, which is about 85% of people with CF, promoting mucus clearance because people can't do it on their own, and controlling that respiratory tract infection that sets in. And for those of you who don't take care of CF patients all the time, if you do need help, on the CF Foundation website, there are guidelines for all the different management aspects of CF that can be pulled up at any time. But when you think about the timeline that Clemente sort of talked about a little bit, things have dramatically changed in CF, even with just taking care of people in a multidisciplinary fashion. So this is data from the CF registry. On the y-axis is the historical and predicted survival, and on the x-axis is the decade. So again, back in 1938, when Dorothy Anderson described the disease, kids weren't living long enough to go to kindergarten. However, as you instituted care centers and began to develop CF-specific therapies through the CF Therapeutics Development Network, which we'll talk about in a minute, survival really did start to increase. And you can see that with the adult standardized care program, because people started to live further into adulthood, that also started to increase the longevity, as did more careful newborn screening. But what really changed everything was the modulators, which we'll talk about. But today, well, at least as of last year's registry, the median predicted survival for somebody with CF is 61 years. And you'll hear at NACFC, for those of you who are coming, that it's now 65. But how did we get here? So it really did make a difference to have standardized multidisciplinary care, but also developing CF-specific therapies was critical, and understanding the basic science to be able to do that was important. So besides instituting the clinical care networks and standards of care and quality improvement through data in the registry, the other thing that was really, really important in CF, which is another orphan disease, so less than 200,000 people in the United States, was the development of the CF Therapeutics Development Network, which was a brainchild of Bob Bell and was instituted by Bonnie Ramsey. So not only did we have these care centers, they started out with 8 centers that really knew how and had infrastructure to conduct clinical trials. So a drug company didn't need to go out and try to find patients with the disease and people who know how to run a clinical trial. They could come to the CF Foundation and say, who knows how to get this trial, and get those patients in who are already at the centers. And that was incredibly important for making it easier to develop drugs. So we started out with 4 different strategies to treat CF. We really focused on the manifestations, the signs and symptoms of CF at first. And then more recently, what we've been able to do is look at that CFTR protein and work on fixing that. So back in 2011, one other thing that I should say is really important that the CF Foundation has done in a way that no one else did was the model of venture philanthropy. So essentially what they did, again, because CF is an orphan disease, drug companies weren't really interested in developing drugs for people who only had about 30,000 in the US and maybe at that point 50,000 worldwide. So the CF Foundation said, we will raise money and invest in your company if you will develop drugs specifically for CF. So they got a lot of money, including from Bill Gates, and invested it in a company called Aurora Biopharma, which later became Vertex. And that is how we ended up in the place that we are today. So first care centers, then a research network, and the model of venture philanthropy. So back in 2011, there were no CFTR protein modulators. Everybody was just receiving symptomatic therapy. But the idea with these modulators was that they didn't actually go and say, well, we need a drug that binds to this receptor. No, they actually did something called high throughput screening, where they threw hundreds of thousands of compounds onto CF cell lines and simply said, does chloride transport get better? So they had a light up GFP that lit up if there actually was chloride transport. So in this way, they said, oh, hey, this drug looks like it might work, so let's work on developing that. And so the idea was that if you had a CFTR protein or chloride channel sitting at the cell membrane like G551D produces, you just needed to make that channel open. And that was a potentiator drug that would do that. For F508del, which currently is the known most common variant, again, for those of you who are who take the boards, F508del is that protein folding defect I talked to you about. So it doesn't usually get to the top of the cell. So you needed a corrector to move it or traffic it to the top of the cell. But that wasn't enough because there were other defects in it as well. And so ultimately what you needed was two drugs at least to one, get it up to the top of the cell and then open it once it was there. But again, this was done through high throughput screening, so this was all theoretical. It wasn't even tested in animal models for function or efficacy, just for safety. So work, really elegant work by Dr. Steve Rowe down at UAB actually looked in human bronchial epithelial cells and said, if we use this drug, at the time it was called VX-770, for cells that have one copy of the G551D variant, something that should respond to it, will that actually make it work better? And hopefully you can appreciate in this video that those cilia are not beating all that well. But shortly after adding VX-770 or ivacaftor to these cells, you can see that the cilia beat frequency was much, much better. So this gave us great hope that this was actually going to work in the clinic. And in fact, that is what happened. So they did 48-week trials in older kids over 12 and in kids 6 to 11. And in these graphs, we're looking at absolute change in percent predicted FEV1, which is our measure of lung function that we use in CF. And you can see that those who were on ivacaftor in blue, immediately within the first 2 weeks of taking this oral twice daily therapy, had a dramatic improvement of 10% in their lung function. And that was maintained over the 6 months. Those in the placebo group, as you expect, drifted down a bit, but as soon as they went on drug, also had this dramatic increase that was maintained over the course of the trial. And that was true in these older kids and adults as well as in younger kids. Importantly, because people with CF have pancreatic insufficiency the majority of the time, people also, this is looking at absolute change in weight, gained weight within the first couple of weeks, and that was maintained over time. And critically, exacerbation rate decreased by about 60%. And why do I say that's so important? Well, because we know from data, again, from the CF patient registry, that every single time someone has a pulmonary exacerbation, there's about a 25% chance they won't get back to their baseline lung function. So every time someone has a pulmonary exacerbation, it's a risk for permanent lung function loss. So if you can prevent exacerbations, then you are going to change survival, because we know that's what affects survival over time. So with the approval of ivacaftor or Kalydeco in 2012, we suddenly had this really highly effective therapy that improved lung function, improved body mass index, decreased pulmonary exacerbations, and dramatically improved quality of life for people with the G551D mutation or variant. But unfortunately, that was only about 4% of the population of people with CF here in the US, and a little bit higher in places like Ireland, but very few of the people who had CF were actually eligible for this drug. But it did set the framework for saying that this is actually a possibility. We can actually correct the basic defect with an oral therapy. Unfortunately for us here in the US, we also were able to show that if you looked at the change in CFTR activity in cells that correlated quite well with the change in the clinic. So I'll just point you to the G551D variant here. So on the x-axis is CFTR activity, and on the y-axis is change in percent predicted FEV1, which again correlates with survival in CF. And you can see that if you could show in cells that you're going to improve the CFTR activity, that also correlated with improving lung function. And the FDA was willing to take that into consideration to expand the label to other variants that were similar in their dysfunction to G551D. So even though we didn't have data, because a lot of those variants were very rare, so you couldn't actually conduct a trial, the FDA said, if you can show in cells that you can improve CFTR activity, we will also expand it to those other variants for people to take it. And so again, more people were able to take that drug because the FDA at the time was the only regulatory body that allowed that approval based only on cell data. So fast forward to 2015 and 2018, at that point, we only had people on therapy if they had G551D or a similar dysfunction in their mutation. But there were two other drugs called Symdeko and Orkambi, so two combination drugs that actually were approved. They did not work nearly as well. So ivacaftor improved lung function about 10%, dropped sweat chloride by about 40. These drugs improved sweat chloride by 10 to 20 and lung function only by 2 to 4%. However, it allowed about 50% of people with CF to have some form of CFTR modulator therapy, and it was able to stabilize them until we were able to come up with better drugs, which we did in 2019 with the approval of elexacaftor, tezacaftor, ivacaftor, or Trikafta. And I'll just show you some of this data because it really was a complete game changer. So I'll just show you, in this case, the data from people who had one copy of F508del, but this drug was originally tested in people who had one copy of F508del or two copies of F508del. So again, we're looking at lung function on the y-axis here and time in the study on the x-axis. You can see that again, with this twice daily therapy, within 2 weeks, people's lung function went up by about 12 to 14%. Not only did their lung function go up, but their sweat chloride dropped dramatically, in some cases into the indeterminate range. Additionally, their quality of life improved. So the minimal clinically important difference for this quality of life measure for CF is 4 points, and people's quality of life scores went up by 20 points within 2 weeks of taking this drug and were maintained over time. Also, their body mass index went up, unfortunately, in some cases very dramatically, and we've had to deal with that in a different way. We'll talk about that a little bit later. But also, as we saw with ivacaftor, there was a dramatic decrease in pulmonary exacerbations in those people who were getting this drug. And it wasn't just that it happened during that 6 months of the trial. When we followed people out further, you can see that their lung function was maintained, which was critical. Again, these were initially done in kids that were older, so 12 and older, and adults. We looked also at kids 6 to 11, so their baseline lung function was much better, usually in the 80 to 90 range, but even when they had higher baseline lung function, you can see that there was a dramatic improvement in their lung function that was maintained over time. And then in this graph, I'm actually showing you a little bit different view of the sweat chloride. So on the y-axis, it's the proportion of people who drop their sweat chloride either below 60 in gray or below 30 in blue. And again, 60 is a diagnostic threshold for CF, less than 30 is CF is very unlikely. So in those kids who had one copy of F508del and a mutation you wouldn't expect to respond to Trikafta, 80% dropped their sweat chloride below the diagnostic threshold for CF and about 6% below the cutoff at all for even having indeterminate CF. And then if you had two copies of F508del, so 2 copies of a responsive variant, 100% of those kids dropped their sweat chloride below the diagnostic threshold, and about 43% dropped their sweat chloride below 30. So really dramatic improvements in CFTR function. We then went on to test it in even younger kids, so 2 to 5-year-olds. So again, their sweat chloride improved dramatically. And of course, all of you who are pediatricians know we can't do FEV1 in those children. So we looked at lung clearance index. And so with that, you want to see it go down rather than up. And we did actually see that again within the first few weeks of the trial. So it was approved for kids 2 and over in 2024 or 2023, sorry. So one of the things that we realized in CF, a lot of the work was done in Australia by the ARREST CF group, is that we see disease very, very early in CF. So even before babies are symptomatic, you can do bronchoscopy and see elevated levels of inflammation in their VAL. You can also see Pseudomonas very, very early. So the reason we do newborn screening is because you catch CF earlier, you can start treating it earlier. So the question is, can we get these modulators down to younger and younger ages? And right now, ivacaftor, Kalydeco is approved down to 1 month of age. So you get your newborn screen positive by the time you get to CF clinic. If you have a responsive variant to ivacaftor, you can start on therapy right away. If you have 2 copies of F508del, you can start on lumacaftor, ivacaftor, or Canby at age 1, but you have to wait until you're 2 if you have F508del and no other responsive variant to start on Trikafta. But one of the things that we've thought about is how low can we go? And really elegant work by John Engelhardt, who developed the CF ferret model, showed that you can actually treat in utero. And so this data is from his CF ferrets. So he had ferrets who had either G551D and a knockout essentially mutation, or 2 copies of G551D. And he treated pregnant kits with ivacaftor in the generally 3rd trimester and showed that for those kits the dams had treatment with during the pregnancy, and those kits who had 1 copy of a responsive variant, some of them actually developed pancreatic sufficiency. So you want to see the fecal elastase go up. But if they had 2 responsive variants and the dam got ivacaftor throughout the 3rd trimester of her pregnancy, almost all of those kits were pancreatic sufficient when they were born because they were treated in utero. We know that the damage occurs in utero, but you can actually prevent it by treating in utero. And so we've now had multiple cases where people with CF were on their modulator and they had a baby that was actually later diagnosed with CF, but their newborn screening was a false negative because the mom had received modulator throughout her pregnancy because she had CF, and therefore the baby actually got exposed the entire time and therefore had a normal newborn screen at birth, a false negative newborn screen. What's even more exciting for me is that there have now been cases also where a mom had her prenatal ultrasound, the baby was diagnosed with meconium ileus. So about 15 to 20% of infants will have meconium ileus diagnosed in utero, but the baby actually was treated by the mom who was a CF carrier receiving Trikafta during her pregnancy. So by giving the mom Trikafta and going through to the baby was born without meconium ileus and therefore did not have to have surgery after it was born. So we are now actually in the process of designing a study to intentionally treat any mom who is diagnosed with an infant with CF in utero, so we can prevent that baby from actually having the complications of CF. So a long way from Dorothy Anderson's children dying of CF to actually treating them when they're diagnosed in utero. So at this point, at least in high income countries, the majority of people have a responsive variant to elexacaftor, tezacaftor, ivacaftor. And I didn't mention that there was a recent approval just at the end of last year for a new triple combination very similar to Trikafta called Liftrec. It's not better than Trikafta, but it's a once a day rather than a twice a day pill. So the majority of people in high income countries have access to these therapies. But one of the things that happened in the phase 3 trials is we only measure those things that the FDA or the EMA cares about. So whether people feel better, they function better, they survive better. We didn't look at all of the other complications of CF in these trials. So there have been investigator-initiated studies looking at some of these questions. So for example, led by Dan Beswick, he and I looked at the study where we know a lot of people, especially adults, have significant sinus disease with CF, and it causes a lot of morbidity, a lot of need for surgery. So here I'm showing you what a normal aerated sinus CT looks like. And then this is an example of somebody at baseline before they started their Alex-Tez-Iva, what it looked like. Then at 6 months of treatment, you can see that it looks much, much better. So about a 25% reduction in the inflammation in their sinuses, and that was maintained over 2 years. We are just in the process right now of looking at the 4-year data. An interesting thing, though, that came out of the study is that even though we could improve a lot of the inflammation in their sinuses, most of these people never required surgery at this point. We could also improve their quality of life related to their sinus disease. We could not improve their sense of smell. So once adults have really severe disease, they lose their sense of smell and it cannot be recovered, even with really effective drugs like Trikafta. However, this led Dr. Beswick to asking whether or not if we intervene earlier, can we actually make a difference? So he's now got an R01 to look at giving Trikafta to little kids and see if we can improve their sense of smell if we intervene earlier. Another question that's been looked at by Pradeep Singh and Dave Nichols and others is whether or not we can improve the amount of infection people have in their airways. One challenge is that when people start on these really effective drugs, they have what they call the purge, where they have all of this mucus coming out of basically every orifice, and then it clears up and they hardly ever cough or produce sputum anymore in most cases. So you can see, looking at sputum produced, it did actually go down for this group of people in the first 6 months, making it a little bit harder to assess their microbiology. But what they showed is that there was a decrease in the amount of infection in people's airways. The majority of people were not able to eradicate infection from their airways. So for those with established disease, we do still need to treat their infections. Another really interesting thing that we saw that wasn't really measured in the phase 3 trials was the effect on lung transplantation. So that's, of course, the last resort for a lot of people with cystic fibrosis. And so in this graph, what I'm showing you just for comparison is COPD in gray and cystic fibrosis in purple. So you can see that prior to 2019, when Eleventh was approved, there were about 200 or so transplants per year in CF. Then ETI was approved, and the number of transplants in CF went down dramatically. And you might say, oh, well, that had to do with the pandemic, but this is why I'm showing you COPD, so the number was pretty steady in spite of the pandemic. And right now, there are more than 10 times more pregnancies in people with CF than there are lung transplants, because it's just been transformed with Eleventh. It stabilized people even with really low lung function so much they're no longer needing transplants. So we were having less than probably 50 a year now in CF across the country. So you heard a little bit about this from Quinte earlier. It saw a similar graph. So this used to be a disease of pediatrics. And in 2015 is where we really saw the inflection point where we started to have more adults with CF than kids with CF. And what we're predicting based on the numbers in the registry is that rather than having 40,000 CF patients in the US over the next 20 years, we're gonna have 40,000 adults with CF because people are living so much longer and so much healthier. But with that comes people thinking about their futures and whether or not they're going to go to work and have families. And we have seen, as I mentioned, a dramatic increase in the number of pregnancies. So we went from having about 200 to 300 pregnancies per year to having close to 700 pregnancies per year in the US. And because it had never been formally studied, never prospectively in the US or elsewhere, we designed the Mayflower study, which has enrolled about 315 pregnant people with CF, and we're following them and their infants for 2 years. So most of them are choosing to stay on their modulators, which of course weren't studied in pregnancy, as most drugs are not. So we are trying to determine how safe it is for people to stay on their modulators, because we do know that people who stop their modulators can quickly become ill. So that data we're hoping will read out at the end of next year for the rest of the women who finished. The last enrollment was in December, so around November of next year, we should have some final data for that first set. We also know that it isn't just women who are thinking about having kids, it's also males with CF who are thinking about having kids. Now, there is CFTR in the cervix, so part of the increase in pregnancies is not just because people are healthier, but also because it's easier to become pregnant when you improve the CFTR function in the cervix. I remember having lots of conversations about this with people, and there were people who didn't believe me and all of a sudden were pregnant within 2 months of starting their Eleventh, and they didn't necessarily mean to be. But for males with CF, unless you get started in utero, you are still going to have CBAVD and infertility, but people do have the ability to get assisted reproduction. So one of our questions was, is it really okay for people with CF to become parents? Kids are, as you who are pediatricians or parents know, kids are really germy, and a lot of infections are initiated by viral infections, or pulmonary exacerbations are initiated by viral infections. So we wanted to ask, what happens to health in the year after parenthood? And the UK registry actually collects data both on women who become pregnant and males whose partners become pregnant. And what we saw was, in fact, people's lung function did go down in the year after pregnancy. Their BMI also went down, and their exacerbation rate did actually go up. So we worked with a group of us led by Tracy Kazmersky to apply to the NIH to actually study parenthood and CF, not to discourage people from having kids, but to figure out which factors were the most important in causing them to have a health decline in that year after having a child in their lives. And so hopefully we can help intervene and not discourage people from having kids. So I spend a lot of time telling you how amazing the modulators are and how they have completely transformed cystic fibrosis, which is absolutely true. It's not a cure, it's pills that people have to take every day for the rest of their life, and they stop taking it, as I said, they can become ill. But there is more to the story than that. So in 1938, when Dr. Anderson described cystic fibrosis in her case series, she pointed out that there was a child who was Black and a child who was Hispanic, and said that the geographic distribution of this disease was wide. But it's been perpetuated repeatedly in every paper up until the last probably 10 years, that this is a disease that occurs in people who are white. And therefore, people who were Black or Hispanic or Asian were not included in the diagnosis of CF, were misdiagnosed, not diagnosed, and therefore didn't get the care that they needed. And if you start to look around the world, this paper by Wodenall shows that it does actually occur in people of every single race and ethnicity, but we just haven't been paying attention. Now that we are actually paying attention, there are probably 50,000 people in India, based on some cord blood studies, that have CF that just haven't been diagnosed because there's no infrastructure, because it was a disease that was taught to be occurring only in people who were white. And that has also impacted access across the globe. So people who are in high income countries have access to this drug, but people who are in low and middle income countries often do not have access. You hear like the last 10% of people who don't have eligibility, but it's actually much, much higher than that. So in this map, you can see that there are a lot of places around the world that have zero access to these drugs right now. And even here in the US, we have inequitable access. So Schreiber and colleagues looked at the number of copies of F508del. So I told you that originally, Alexa's was approved for people who had at least one copy of F508del. So the number of people who didn't have copies of F508del was in fact 10% for people who were white. But if you looked at people who were Black, Asian, or Hispanic, the higher percentages of those folks did not have a copy of F508del and therefore were ineligible for this drug. Suzanne O'Connell and Meg McGarry actually looked at the CF registry and similarly showed that yes, if you were white, you were almost always able to access these drugs or have eligibility for them. But if you were Indigenous, Hispanic, Black, or Asian, you were much less likely to have variants that were qualifying you for these drugs. And part of the reason for that is because, again, it was taught to be a disease that occurred in people who were white. So the variants that were studied in all the cell lines were those of people who were white and not those of minoritized groups. And then my fellow last year at Children's actually showed that even if somebody was actually eligible, if they were Black, Hispanic, or Indigenous or Asian, they were less likely to be prescribed the drug later. So the bias in our healthcare system still does exist. They've also shown this for newborn screening. So even if a newborn screen is positive, if you're Black or Hispanic, you're going to get a later push to go to the CF clinic than if you are white. So we have a lot of work to do. So we have this group of people who is less likely to be diagnosed and then less likely to qualify for modulators. And now even they're still less likely to be prescribed modulators. So again, the bias in medicine still exists and we have a lot of work to do. But the good news is that if we actually are intentional about our behaviors, we can actually change it. So this is data from the registry that shows the eligibility based on the phase 3 criteria. And then Martin Mintz, who leads the CF laboratory, actually really focused on variants that were uncommon, more likely to be seen in people of color, and showed that if you actually tested those variants, then you could improve it for everybody. So it wasn't a zero-sum game. You looked at more rare mutations, and then there were a lot more people, white, Black, and Hispanic, who all qualified for these modulators based on intentional efforts to include more rare variants. So we can do it if we think about it and are intentional in our behavior. Another problem that we have is that not all who are eligible are using modulators. So this is a busy slide, but I'll just have you focus on the last column. So that first number shows how many people are eligible, and then the bottom number shows how many are actually taking the drug. So again, I told you there's some bias in prescription, but the other issue is that there are side effects to these drugs. And so there are some people who just can't tolerate the drugs. They're metabolized by the liver, so we have to monitor liver function, and some people's liver function becomes abnormal when they're on these drugs and they have to discontinue. There are also some people who develop severe rashes, and there is some association between these drugs and anxiety and depression. So some people just can't take them. So we still have people who, even though they're eligible, are not able to get these drugs as well as they work. So in our current registry, if you look at just the variants that are eligible, we think that up to 94% of people have the protein there that could be modulated by one of these drugs. For those who don't have one of those variants, there are other methods that we'll talk about in just a second, but it's also really, really important to know, especially for me as a clinical trialist, is that when you look at who is not eligible for these drugs, it is people who have lower lung functions. There are always eligibility criteria for these new studies. You have to have a lung function over 40, it has to be 1 over 40%. So people in this group have lower lung function. They're more likely to be lower income and on Medicare or Medicaid, meaning that they probably are going to have less easy ability to get into a clinical trial site and spend 8 hours at a clinical trial site because they have to be at work. Also, they may not be seen at a CF Therapeutics Development Network site because they're rural, and so it'd be very difficult for them to get in to do these clinical trials. And then finally, they're more likely to, as I showed you earlier, identify as a person of color. And there are historical and ongoing issues of bias and racism in medicine that makes people less likely to want to participate in a clinical trial. So we have a lot of work to do to try to get people ready to be in these clinical trials and enable them to actually be in these clinical trials of these new therapies. But it's really, really important. I worked with another nonprofit called Emily's Entourage, and we surveyed people with CF across the world and talked to them about the fact that they were not eligible for modulators and how that was impacting their mental health. So this is a quote from a parent that said, "The older my child becomes, the harder this disease becomes to manage physically and emotionally. It's extremely hard to watch as it slowly takes over." And then from a person with CF, I'm 42 and I feel like I'm running out of time. My only CF issue is my lungs. My last call with my doc, he said, "I wish I had a modulator for you." Same doc, same. And then from a spouse, "I'm glad so many have access to CFTR modulators, but at the same time, I'm concerned for my partner. I worry that 90% coverage could be seen as good enough, and I worry about the effect being passed over of these incredible drugs has on his mental well-being and physical and mental health." So those people who aren't eligible are really suffering as they watch. They're happy for the people who have them, but it's really hard for them to see people doing really well and they're still having the old CF without these modulators. So where are we going next? So what we really have to do, both to help those who don't have eligibility for these modulators and to develop a cure for CF, is focus on nucleic acid-based therapy. So really reprogram the cell to make the functional CFTR protein that they need. So there was a great analogy by Martin Mintz and Hilary Valley at the NACFC maybe 6 or 7 years ago. And so they said, think of CFTR as a car. So the car is the CFTR protein, the different mutations are the different car problems. So in the case of mRNA therapy, it would be like having a rental car. mRNA is very short-lived, so you give it to the cell, it makes the correct protein for a little while, but you're gonna have to keep giving that therapy over and over again. Whereas with gene therapy, you're actually replacing the whole gene, so that's like having a brand new car. Versus gene editing, where you're actually going in and fixing that specific mutation, as they've been able to do in sickle cell. And so then if you get that in the basal cells, then you hopefully got a one-time shot where you're just correcting the gene and actually curing CF. I mentioned earlier that back in 1989, when the CF gene was discovered, we thought gene therapy was going to be around the corner. Unfortunately, there was really inefficient transduction of the cells, and it was causing a huge immune reaction. So after several trials that were very unsuccessful, people sort of went away from that and focused on the modulator therapy. We are now back in a space where we're actually doing gene therapy and mRNA therapy. So I'll just, in the interest of time, show you 2 studies. So this one is an AAV. So AAV is a relatively small vector. So you have to modify CFTR a little bit to actually fit the whole thing in. But for the first time, we were actually able to show that if you inhaled this AAV vector, we could get the corrected gene into the cells that we meant to get it into, including some basal cells. So both by immunohistochemistry and ISH, for the first time we were actually able to show that we did get the vector where it needs to be. And this trial is ongoing with different doses of the 4D inhalation therapy. There are also 3 different companies that are trying to advance mRNA therapy. So they're putting corrected mRNA into lipid nanoparticles and having people inhale it. So this is just an example, again, using the CF ferret model of what the movement of mucus in the trachea looked like in the ferret before they got this recode mRNA therapy and what it looked like afterwards. So again, this ferret data was very, very promising that this would actually work. And this drug, this inhaled mRNA, is under current clinical trials now. So we continue to have this massive pipeline. This is just the things that are being funded by the CF Foundation, looking at the different phases of the drugs and those that have actually been approved. So correcting CFTR, actually improving mucociliary clearance, anti-inflammatories, anti-infectives. There are still lots and lots of drugs in the pipeline, but what our real goal is really to be able to offer corrective therapy to those people who don't have current drugs, but while still treating the disease that people still have. Because if you have established disease, even Alex-Tez-Iva isn't going to be the only answer for your disease. So this is one of our patients who gave permission to show this picture. So back in the Kalydeco days before it got approved, he was one of the people that went to the FDA to actually testify and say, please approve this drug. I could feel the difference within 12 hours. And at the time in the State of the Union, Obama said, I want the country that eliminated polio and mapped the human genome to lead a new era of medicine, one that delivers the right treatment at the right time. In some patients with cystic fibrosis, this approach has reversed the disease that was once thought unstoppable. So going back to our patient from earlier, remember he's a 35-year-old Southeast Asian man who was misdiagnosed for many, many years, mainly because he was Southeast Asian. People didn't think he could have cystic fibrosis. And even when they did actually test him, they only did a 32 mutation panel, which is insufficient for somebody who's likely to have a rare variant from another country. So once we diagnosed him, there weren't any therapies that were approved for his rare variant. However, because he clearly had pancreatic insufficiency, both by fecal elastase and his history of not having greasy stools or difficulty maintaining his weight, I appealed to Vertex and then to the FDA for an individual IND so that he could actually get ivacaftor or Kalydeco. And so you can see that he started in June 2015. This is data from an individual registry. So this is lung function on the top and his BMI on the bottom. And you can see that his lung function didn't go up a lot when he started on ivacaftor, but the difference was that he wasn't getting IVs every single month and therefore no longer at risk of losing his job and therefore being deported. So he did eventually move to a state with lower altitude because his lung function hadn't gotten up a lot and he felt a lot better breathing without any oxygen at sea level, but he was able to stay out of the hospital. And since he started on ivacaftor back in 2015, his variant is now approved for Trikafta, and he went on Trikafta. He's had no hospitalizations since he started on the CFTR modulator. His son is doing great and doesn't actually have CF, it's just a carrier. So this case I show to give the example of, again, this drug or this disease that occurs in people of all races. You can really set people back by misdiagnosing them because this guy does not have to have a lung function of 38%. He could have been a lot better, but also you as an individual physician can make a huge difference in somebody's life. So he wasn't approved for those variants, but we pushed really hard with the company, with the FDA, and he is still alive because of that. So in conclusion, although CF is more common in people of European ancestry, it can occur in people of any genetic ancestry. We have this really highly effective therapy that impacts the basic defect for about 90% of people with CF. However, we don't know all the effects of these drugs, and we are continuing to study them in real-world studies, and there are people who don't qualify for these drugs or can't tolerate them. So we do have this robust pipeline, and there are numerous shots on goal right now to first treat everybody, but also to cure CF. So with that, I'll say thank you again to the organizers, people with CF and their families who participated in these trials, and all the research centers, as well as those who provided slides. And okay, let's just a few minutes for questions.
Well, thank you very much, Dr. Taylor-Cousar, for this wonderful talk, and the floor is open for questions.
Thank you for that simply wonderful talk. It was really inspiring and exciting to see all the advances that have been made. I'm curious to know your perspective on the role for the modulators in conditions such as COPD with bronchiectasis, chronic sputum production, building on the phase 2 trial of Entecavtor that didn't reach its primary outcome of FEV1, but did have some benefits for sputum and cough and other symptom scores.
Yeah, it's a great question. And I think the bottom line is that if this drug didn't cost $300,000 a year, we would just be trying it in a lot of people, including those with CFTR-related disorder or things like COPD, where you have environmental effects that cause CFTR dysfunction. So I do think there is a role. The problem really comes down to getting it covered. And even, we talked about this a little bit in some of our meetings today, it's come down to the fact that when we have people who have a questionable diagnosis, and whether you call them CF or CFTR related disorder could make the difference in whether their insurance company would actually cover this really expensive drug. So a lot of us are leaning towards calling people CF, even if they don't meet the classic criteria, because like, for example, John and I were talking about a patient I have who has sweat chlorides in the 70s, and he only has 7T, even on Ambry. But I'm like, okay, he's got bronchiectasis and centrophimosis and sinusitis. So he's, in my mind, CF, because before we had genetics, we just went by clinical symptoms and CFTR function. So I got Trikafta that fell off the truck and gave it to him for a month, and his sweat chloride went down to 30 and his lung function went up 6 or 7%. So I'm using that data to try to say to his insurance company, look, this drug actually does work for him, so please cover it. And so far it's working. But this is the problem, is that we've got to really develop other drugs that compete with the current ones that are available so that we can get the price to come down, because we could use it in a lot more people, I think, successfully.
Thank you.
Wow, you covered a lot of impressive territory and great advances. A couple of things come to mind. One is, I was worried with your slide that there are not CF centers in some, pretty important states. Arizona has a pretty big population. Look like New Mexico, we've got some Yaleys out there. Maybe we could do something about that. How many states don't have a CF center?
So the map that I showed was just the TDN sites. We have about 200 centers all together, but there are states like Wyoming that don't have a CF center. So in Colorado, part of the reason we have the biggest CF center in the country is because there are a lot of surrounding states that don't have centers. And so people have to drive down to Colorado to see us. And part of the issue is that, especially now, there are so many adults with CF, there aren't enough adult doctors trained in CF. So when I was in New Mexico briefly while my husband was in PA school, I was the only adult CF doctor in the entire state.
Yeah.
And so there are lots of places where there are none. And it's hard to attract people to some of those more rural and frontier states. And so unfortunately, people are forced to go to surrounding states for their care. And for the TDN sites, again, you have to have the research infrastructure. And so there are only about 90. We are actually cutting them down a bit because we have fewer trials now. And so what we're trying to tell the drug companies is that if you want people in your trials, then you're going to have to pay for their travel, because they can't afford to drive, even from New Mexico to Colorado, for example. So the drug companies really have to help get these trials done by paying for people's travel.
So now what's going to happen, because many of us believe this Medicaid cut is damn sure going to go through. What is this going to do for treatment for CF patients as you project?
Some people are going to die, quite frankly. There's data in the literature that shows something called ivacaftor withdrawal syndrome. The people who ran out of their insurance in North Carolina, it was a case series of 3 people, and they got really sick when they stopped taking it, and one woman unfortunately actually died. So if people are dependent on their Medicaid to get their Trikafta, they're going to get really, really sick, and some people will, unfortunately, especially those with more severe disease, will die if they can't get their Trikafta.
Guess I'll take a point of privilege and ask a question. So could you comment a little bit, Jen, on the difference in sex-specific differences as it pertains to response to treatment? Is there a difference that you can see in the presentation or in the response to treatment?
Yeah, it's a great question. So for those of you who aren't aware, there's long been a sex disparity in cystic fibrosis where women with CF have more morbidity and higher mortality. And we think that's related to estrogen. There was a paper out of Ireland, gosh, I don't remember what year this was anymore, a while ago, that showed that women who were put on oral contraceptives, so they were no longer cycling, had less exacerbations. And so there definitely was a sex difference prior to the modulators. We don't know exactly right now whether or not if you look at all the supplements for the New England Journal papers, there is often a little bit of a difference. And there has been data from the ivacaftor work that showed that women had a lower sweat chloride than the males, but they still were having as many exacerbations. And more recently, there was a paper that showed women, even on Trikafta, are still having more exacerbations. Again, it's probably estrogen related, but it's something that needs to still be sorted out.
Let's just see if we have anything on the chat here. So Jonathan Rosen asks if there are any TDN sites still doing nasal PD for rare mutations.
Yeah, we in Denver actually still are able to do nasal PD. So for those of you who aren't aware, you basically put in a catheter and run various solutions through to stimulate the chloride channel to determine if somebody has CF. So it's a more sensitive measure than sweat test, but is very complicated to get that data up and, get the setup up and running, and it sort of looks like a mad scientist setup. And so there aren't very many centers across the United States who are still able to do it and actually interpret it, but there are, I think, about 10 across the US.
All right, any other comments from the audience? All right, I think we'll conclude. Thank you so much.